As all clinicians, I'm very interested in new treatments that may have efficacy for the many disorders for which our currently available treatments are inadequate. You know, in my field, partial response is the norm for people with depression, with schizophrenia, anxiety disorders like PTSD, sleep disorders, and others. And so new treatments are needed. At the same time, patients with these illnesses deserve treatments that have proven efficacy and a well-understood safety profile. So that's really where I see our challenge. And in my opinion, the National Academy's report really emphasized that the quality of data that we have in most areas is poor. And that's where we need more research, because it's my mom is on dronabinol. She's advanced dementia and is taking that. It's a FDA-approved form of THC to stimulate her appetite. At MGH, we're one of the biggest sites for a pediatric epilepsy trial for cannabidiol. It's a purified form of cannabidiol of known constituents, known composition and known purity for children with 3 different forms of epilepsy. And thankfully, it's actually showing some substantial promise. Two papers are about to be published. So there's real hope there that with well-done research, we can understand components of the marijuana plant that may be purified, known purity, and be able to be used safely by people with various illnesses. So what did we take away from this enormous, 600-page report that looked at started with 24,000 abstracts and boiled it down to a mere 10,000? What they came out with is that there is either substantial or conclusive evidence of efficacy for cannabis or cannabinoids for chronic pain. Now, there's so few studies that they lumped all chronic pain together. Now, all chronic pain does not respond in the same way. So because there's so little research, quality research, they lumped it together and said, okay, there's substantial, actually almost conclusive evidence that there's efficacy. That doesn't speak to safety. They looked at safety separately, and I'll talk about that. So for chronic pain, for nausea and vomiting due to chemotherapy, there's substantial evidence that it can be effective. And oral cannabinoids for patient-reported spasticity for multiple sclerosis. So these are areas for which also there's reasonable preclinical data to suggest that there's reason to believe it should work, which is really part of the medical discovery process. You understand that there's a reason it could work, and then you go on to purify it and see what works, and then you look at it in clinical trials. For all other indications, the level of evidence was moderate or lower for efficacy. Right? So there are really 3 categories for which there's some pretty good data that there's efficacy. We still need to understand safety. For all others, we need to do more work. Either there's evidence for no efficacy, or there's only fair evidence. And one of the reasons for this is because much of the research is of poor quality. Dr. Adger mentioned that the New England Journal report gave high confidence for the findings of a number of the safety concerns about marijuana. Right now, there's fairly low confidence of the findings for many of the trials, for many indications. Okay, so that's what this last bullet point is. Maybe you can make a general conclusion, but the limitations are such that the confidence is low in the findings. So we really need more work in order to work out safety and efficacy. In terms of safety, there was substantial or conclusive evidence that cannabis use is associated with development of schizophrenia, particularly with early use of high-potency cannabis. Doubles your risk of motor vehicle accidents, at least. That's with basically older studies with lower potency cannabis. It's associated with low birth weight. And low birth weight in and of itself is not a disease, just like high cholesterol in and of itself is not a disease, but it's associated with numerous complications. So if anybody read the Times today, there's all these testimonials of pregnant women using cannabis for their nausea, but there's really substantial evidence for low birth weight complications for use during pregnancy. And high frequency use is associated with essentially dependence. There's also moderate evidence, and this is the one moderate evidence finding that I want to highlight. It's in my field, and we do know that there are molecular mechanisms underlying gateway, essentially, mechanisms for use of one drug, especially early in life, increasing the risk of addictiveness for other drugs. And there's moderate evidence for that with cannabis, which is fairly new information. So we know that, say for nicotine, so we know that, say for cocaine does not need a lot of help being addictive, right? But if you are exposed to nicotine first, you are more likely to become addicted to cocaine than if you weren't exposed to nicotine first. And there's molecular basis for that that's pretty well understood. And this may be what's happening with cannabis, essentially lowering the bar for those who are exposed to other drugs becoming addicted. So I want to talk a little bit about what's a medicine. And what is a medicine? It's codified in the Controlled Substances Act. Okay, so there are 5 very simple criteria. A drug's chemistry must be known and reproducible. The safety evidence must be adequate so that you can speak to short-term safety if it's an acutely used drug, but many of the diseases for which cannabis is being tried for are chronic diseases, so we really need to understand long-term safety. Evidence for efficacy must be adequate and well-controlled, and I'll talk about what that means. And then these last 2, basically experts should agree that it's a useful drug, and the evidence should be available. It can be examined independently. So to speak a bit to the drug's chemistry, known and reproducible. Leaf cannabis or flower cannabis composition is not known, and in fact it's changing over time. Dr. Adria referred to that here. This is percent THC in seized cannabis on the streets of America over the last several decades. It's going up, and this has safety implications in terms of impairment of motor function, driving accidents. In terms of addictive potential, THC is much more addictive than, say, cannabidiol, which has virtually no addictive potential that we know of. In terms of toxicity, psychosis, etc. And to further underscore the fact that we don't understand the chemical compositions, this is an analysis of fairly old THC. This is about 10 years old, 8 years old, leaf cannabis, compared to, so machine smoked cannabis cigarette versus tobacco cigarette. And this is just, you can see the third table is cut off because it was just too long. The number of constituents in smoked cannabis is enormous, and many of these have psychoactive components, and many others have effects in the body on the immune system, are carcinogens, etc. So the carcinogens in this cannabis are much lower than in a tobacco cigarette, thankfully. But anyway, the requirement for known composition as a medicine is clearly not met in smoked cannabis. And just to talk a little bit about THC and CBD, CBD is cannabidiol. It's what's being studied for epilepsy and other indications. And THC really is the addictive component in cannabis. And as the ratio of THC to CBD has changed, has gone up, the risk for anxiety, for psychosis, and for addiction has changed and gone up. So as you see in the first column, THC is quite active in the reward system in the brain. CBD is not, and in fact, it may have opposing actions in the reward system of the brain. THC is the intoxicating substance in cannabis. CBD does not have intoxicating properties. THC is what impairs cognition, and in fact, CBD may be beneficial for some forms of cognition. So you get the point. Essentially, you call me old-fashioned, but when I want to study a medicine, I'd like to know what's in it. And therefore, if I find in the study that it works, I can say what it is that works and what dose works and for who. So I think that this is where we need to go with cannabis research. Cannabis research is in its fairly early stages, okay? And a majority of the studies still have major flaws. For safety, these are what I think we need to highlight. We need to understand better acute effects. We need to understand the intoxicating effects. What are the effects on driving, et cetera? What are the effects on performing your job? Long-term effects, what's the potential for addiction, for different formulations? Again, even the ratio of THC to CBD may have major impacts on this. On brain changes, I'll show you some of our data on cognitive impairment, psychosis, life outcomes, etc. There's not a single randomized controlled trial so far that has investigated adequately long-term safety. Okay, so if you want to prescribe this for multiple sclerosis, you need to understand long-term safety, I would say. So this is just, you probably are aware of this, the FDA approval process. It usually starts with preclinical studies. You see an effect in an animal model of a disease. You do phase 1 trials to establish safety and healthy controls. And then you do a phase 2 trial where in a small number of subjects, usually a few hundred, you see, okay, does this work? Does it seem like it's going to work? And if it still looks good and it looks safe, you do large-scale studies. Then you can understand subgroups of people for whom it might work in and it might not work in. You look at sex differences, et cetera. And then it gets submitted to the FDA. So there are a few indications for which it looks like there's substantial evidence that cannabis may be effective. Like 3, okay? Chronic pain, nausea and vomiting, and self-reported spasticity. This is just a little selection of the conditions for which medical marijuana has been approved by a voter initiative. You know, as a physician, I'd much prefer to see the FDA process followed because patients with these very serious disorders for which effective treatments do exist are often turning to cannabis now first. I've had colleagues, John Alpert runs our clinical program at MGH, you know, come to me and say, what do I say to patients who want medical marijuana? I've had people who I've been treating for years are now telling me that they've been taking marijuana for their depression for many years and they want now to do it, you know, legally. They want me to certify them, but there's no data. And so what do I do? It's a real conundrum. There are FDA-approved cannabinoids that are available and are used and can be used. At least you know the purity. At least you know someone who's immunocompromised, who's using it for pain, is not going to develop a fungal infection in their lung and die, which has been reported recently because of impurities in the leaf cannabis. So basically, leaf cannabis does not meet any of the 5 criteria, federally determined criteria for a medicine. How can we change that? How can we impact that and actually pursue what may be a hopeful treatment for some for illnesses for which we have inadequate treatment? Well, the endocannabinoid system really is effective for analgesia, or it's the receptors in analgesic regions in the brain. Medical marijuana has been proposed as a potential treatment, but there's a lot of uncertainty that we need to sort out, I think, before this is rolled out in a big way. Specific indications are unclear, ideal doses and adverse effects are not well known. But it's really the most promising area, I think, of all the dozens of indications that are now, codified in laws in various states. There is preclinical evidence that says that the endocannabinoid system may be an important target and a useful target in pain. I've listed some of the findings there, but clinical evidence is weak. The gold standard, what we judge medicines by, are double-blind, placebo-controlled clinical trials, and preferably, if there's an active treatment, there's an active control as well, so you can compare the new drug to the standard treatment. So you get a placebo control and you get an active control, so you can really judge how good is it. Few exist for either cannabis or cannabinoids. The studies that have been out there are small and they've largely been unsuccessful. There's a review 2 years ago in JAMA that really looked at the world literature on medical marijuana. And you can see in the upper right-hand corner, the numbers of trials are quite small, and the number of patients in each trial or in the aggregate is quite small. Like you see for glaucoma, 6 people. For anxiety, 24 people, right? These are not big trials. And if you look at the way the grading of the trials, basically the level of evidence, how good is the evidence? You can see that most are very low or low quality evidence. So that means, okay, there's a hint that this might be useful. We need to follow up on this in well-controlled trials. And what do I mean by that? There are a few like classic sources of bias in clinical trials. And bias just means you systematically misinterpret the data. And what we see in a lot of the cannabis literature are like 3 major problems. And this gets a little wonky, sorry, but completer analysis. So you enroll 200 people in a trial, but only 50 finish the trial. And you do all your analyses on those 50 people. So 50 is your denominator, essentially. So if 25 people get better, that's a 50% response rate, right? Rather than a 10% response rate. Same for adverse events. You basically overestimate, because why do people drop out? Didn't work, they had an adverse effect, or something else. But there's a fair bit of that. So you tend to overestimate the efficacy and underestimate the adverse event profile. And both of those are really critical. If you go to your doctor, you want to know, what are the chances this is going to help me, and what am I likely to experience that I'm not going to like, okay? There's selective outcome reporting, there's inadequate description of the trial, but the small sample sizes are a big problem. And a problem that may not seem like a problem. Many studies only enroll experienced cannabis users. They may only enroll people who report a positive response to cannabis. Well, what's the big deal? It's a placebo-controlled trial. Well, if you've used cannabis before and liked it, you're less likely to have an adverse reaction than the general population of people, say, with MS who've never tried cannabis, right? So again, it reduces the estimation of adverse effects, right? So you're not getting complete information that would be applicable to the average person who walks in your door and says, I've got spasticity and nothing else is working for me, doc, what can you do to help me, right? So in this JAMA paper, only 5% of all the studies in the world literature were considered to be at low risk of bias. So we can fix that, right? We can get pure cannabinoids, we can study them, and we can understand the risks and benefits better. And so cannabis is a natural product, there are no risks, right? Well, I'm a tobacco researcher, tobacco is natural, and that's pretty much been debunked. But just a few things that we've done in our lab that give me pause. Okay, so we studied, this is from Jody Gilman's work, she's a junior faculty member in our group. She studied, we work out of Boston, there's 70 colleges in Boston, plenty of college kids. We enrolled college kids who are smoke pot but don't have addiction to it, and those who don't. And we did brain scans, et cetera. And we found that those who used pot had change in their neuronal density in their brain in the nucleus accumbens, which Dr. Adger mentioned as the site for dopamine release and addiction. So they had basically brain growth. Well, brain growth, that sounds good, right? Except this is in the addiction region of the brain, and this really probably is what underlies the problem that addiction's a lifelong disease. That has, once you're addicted, you have craving. You have risk for relapse for life. Many people are in recovery and they stay there, and that's fabulous. And addiction is a good prognosis disorder these days, but there's a risk for life. We also see brain shape changes. This happens to be in the nucleus accumbens, but we also saw it in the amygdala. And this is correlates with amount of drug use, whether you look at how many times you smoke per day, how much you smoke per occasion, how many joints per week, and smoking days per week. This is cross-sectional. So maybe these people were born this way. Maybe there's no relation to cannabis use, except that you see the same changes if you give THC to rats. So if you give no THC, you don't see the brain changes. If you give a low dose, you see some increased density in the nucleus accumbens. If you give a higher dose, you get more. So the fact that it's reproducible in animals raises my confidence that this does have something to do with the THC and something to do with addiction. Just a couple more. This isn't without risk. These are a bunch of kids aged 15 to 25. These are not addicted. These are people who are in school, either in high school or college. We looked at how well they could learn and remember. So people have talked about memory changes with cannabis use, particularly early onset. Well, we found memory problems, but we found them directly related to encoding problems. They couldn't learn as well. This is just list learning. This is a California verbal learning test. You have to learn a list of 16 words, and this shows you just how many words they could learn and how many they remembered over multiple trials. And if you started smoking before age 16, there's a major problem. If you started smoking after age 16, there was no different from controls. Okay, so kids are particularly potentially at risk. Just 2 more slides. This is another group of people that may be at increased risk. This is another learning test. These are 4 different components of the California Verbal Learning Test showing controls, people who don't smoke pot at all, people who smoke pot but don't have an addiction to pot, so these are particularly heavy smokers, about weekly, who had reduced performance, that's the red bars. People with major depressive disorder, we know their memory issues with major depressive disorder. They had problems about comparable to those who smoked pot. But if you had major depressive disorder and you smoked pot, you had a very impaired memory on this task, and it didn't matter how you sliced it, right? So that may be a group of people for whom medical marijuana may not be a great idea. They may be more vulnerable to cognitive effects of early cannabis use. And these are the kind of things that we need to learn in well-controlled clinical trials while we're looking for medical benefit. And just a thing to speak to addictiveness, that's the other thing. Oh, pot's not addictive. Well, we've been paying high school kids to quit smoking pot. For about $400, $460 actually, we can get 93% of high school kids to quit smoking pot for a month. No problem. They quit smoking pot, and this shows the level of carboxy-THC in their body, and we wanted to see the effect of stopping on their ability to learn. At the end of 4 weeks, almost all of them said, man, you know, I feel better. I didn't think I had a problem before, but I feel better. I'm going to quit using. Or at least I'm going to use really a lot less. As soon as we quit paying them to be abstinent, you can see what happened to their carboxy-THC levels, right back up. In fact, they were higher 2 weeks later than they were at baseline, although granted there's more variability. So some people did reduce, but they went straight back to using. And one thing we saw was the kids that were in this trial who had a psychiatric diagnosis, their withdrawal symptoms lasted a week longer than those who didn't have a psychiatric diagnosis, right? So it's a small sample, it's 25 per arm, and the psych diagnosis that they had might have been ADD, that was most of it, but some had anxiety, some had depression. But those who had one of those diagnoses had a full week longer cannabis withdrawal syndrome than those who didn't have a psych diagnosis. So that might be another group for whom the risk is a little too high for medical marijuana, right? We just need to understand that better. And this may be why people with psychiatric illness have much greater chance of developing problem cannabis use if they start using cannabis.